Everyone, welcome to this morning's Albert Ashuli Grand Round.
Recording in progress.
So we have Dr. Makwa, who is going to present the case to us. Thank you.
Good morning, colleagues. The case that we are presenting today is Ms. NM. She's a 32-year-old Garuda 3 para 2 at 24 weeks and 4 days. She's a booked patient, rhesus positive, syphilis negative, and HIV positive. She presents with chest pains. What further history would you like to take?
Yeah. I don't know what the new registrars are. Ask Nyameka. Nyameka is online.
Nyameka, Dr. Malulega.
I'll start with the history of the presenting complaint. Start with where the pain is located on the chest. Exactly. The character of the pain. Is it a sharp pain? Is it a dull pain? Is it associated with breathing? Thinking of origin like pleuritic chest pain. So is it associated with breathing? Is it a constant pain, or is there something that aggravates it? Maybe stressful conditions. Okay. Yes. When did it start? Is it a gradual becoming worse kind of pain? Like, yes. Or it was just a sudden onset of pain? Is it radiating anywhere? Trying to explore any cardiac origin of the pain. Is it radiating anywhere to the chest, to the jaw, or the shoulder? Kind of pain. Any associated symptoms like cough, because it may be associated with the respiratory problem. Is there any association like difficulty in breathing? It could be respiratory or cardiac. Is there any associated fatigue with the pain? Moving on to her obstetric history.
Oh, okay.
Sorry.
Okay, Dr. Nyameka, I think we'll stop you there. Thank you. So she presents with this first episode. It was a sudden onset. It's a retrosternal crushing chest pain. She describes it as continuous and worsening. The pain occurred at rest with no exertion, and it radiates to the left arm and neck. It's associated with sweating, shortness of breath, and syncope. And she also reports that she has had 2 syncopal attacks 3 weeks prior to this presentation, but she did not seek medical attention for it. Furthermore, she has no cough or other constitutional symptoms of TB or a TB contact. There are no palpitations. And with the syncope or pre-syncopal attacks, there were no headaches, oral, or she hasn't had any seizure or any visual disturbances. There are also no associated GI symptoms. such as nausea, vomiting, or dyspepsia, and also no symptoms of a DVT or any recent prolonged immobilization. And in terms of anything to relieve the pain, she hasn't tried any medications to relieve it. And then you asked about a past obstetric history. So she is gravida 3, para 2, 2 NBDs. First one at term 2015 with no complications. And the second one was in 2019, also NBD at term, but she knows that she had hypertension in this pregnancy. I think I might have led on a bit, but anyone else have anything more to ask from this point forward? Dr. Gomete? Oh. Okay.
So it's just a patient who has had chest pain. So it was a 32-year-old.
Gravida 3 para 2, she's at 24 weeks and presents with chest pains. Central crushing chest pain radiating to the arm, with associated sweating, shortness of breath, and syncope. So we've just
So it's gone into presenting of very clinical inquiry, and she's done a bit of past obstetric history. What more would you like to ask from systemic inquiry on this particular question, or the past medical history? Let's start with past medical.
So maybe if she had had any previous hospital admissions, maybe if she had any comorbidities like medical conditions. In terms of the chest, well, is it the first episode she's having this chest symptoms?
And more like past medical, probably complaining of central chest pain. What are some of the associated things that you're going to ask in the case that might give you central chest pain?
So maybe a previous history of maybe diagnosis of hypertension, maybe any cardiac or myocardial infections, any history of smoking and diabetes, and any history of drug history that she may be taking or alcohol use.
So our patient, as we said, is HIV positive. She's on treatment or diagnosed in 2015 and currently on TLD. And CD4 count at booking was 442 with a suppressed viral load. She's never had any past opportunistic infections. She has chronic hypertension, or was on hydrochlorothiazide since the last delivery. No further workup was done for this. And in this pregnancy, she's been switched on to methyl dopa 500 milligrams CDS. No other significant personal medical history that she gives us, and no personal or family history of venous thromboembolism. She has never been operated or has never had any surgical interventions done, is of sober habits, and has no significant family history of any cardiac disease, and so forth. And from this point, how would you like to proceed? From somebody online.
Yeah.
Dr. Stolle? Dr. Kamede, do you want to give it a try?
What did you
Any other volunteers from the online team?
I think
Thank you, Dr. Gomede.
Okay. So in terms of examination, so firstly I'll start with general appearance of the patient. We'll do vital signs, blood pressure, heart rate, respiration rate, and also the weight and the height so that we can calculate the BMI of the patient. Bedside investigations, we'll do a urinalysis for her and also do a GM to check her blood sugar levels. And then moving on to check if there's any signs of anemia, check if there's any bilateral edema. And then on to the chest, I'll do a neck and thyroid examination for her since she's young, to check if there's any signs of maybe hyperthyroidism, if there's any enlarged thyroid, and also look at the chest if she's not in distress, listen to the heart sounds and lung fills, and then go into her abdominal examination. She's
32, yeah, 24 weeks pregnant.
So I'll palpate the abdomen, grab the uterus if it's soft and tender, any palpable masses, and other signs of check. And also, so I'll just do full clinical examination of the patient.
So for this patient, these were vital signs. She had a blood pressure of 188 over 113. Her pulse was 91. Respiratory rate was 24. She had SATs of 98%. Her GM was 5.2. We also did a ward HP, which was 12.5. The calculated BMI was 33.4. And on general exam, she had a GCS of 1515. She was diaphoretic with mild tachypnea. She was also noted to have mild temporal wasting, but was not pale, felt warm to touch, and had no goiter. She also had no edema. The calves were soft and not tender. And on further cardiovascular exam, her manual pulse was 75. It was regular. Normal volume and all pulses were palpated and equal. The JVP was not elevated. Apex was in the 5th intercostal space. It was normal with normal heart sounds and no murmurs. His chest examination was clear. And on the abdomen, it was also soft, it was not tender, and the uterus was appropriate for gestational age, and there were no other palpable masses. And then in CNS exam, her cranial nerves were normal. She had globally normal power and tone. And so the assessment was made of a 32-year-old, gravida 3/2 at 24 weeks, HIV positive and virally suppressed on treatment with chronic hypertension, and now acute onset central chest pain with syncope. Any differential diagnosis from this point? Any volunteers on the floor?
She's 32.
Alvin.
One of the differentials would be we like to do preeclampsia to see the features. We would like to do it.
So what to speak up to the features? It's not very helpful.
Superimpose.
Yeah.
Correct. Definitely superimpose the preeclampsia. Acute myocardial infarction. Any possible cardiac failure like microvalve disease, arrhythmia,
Okay.
Anything else? Just pain. Pregnant patient. Yeah.
Yes.
Yeah.
So at this point, in agreement to the opinions given on the floor, this was a differential diagnosis. So first of chronic hypertension superimposed with severe preeclampsia, a PE, cardiac pathology, as we said, an acute coronary syndrome such as a myocardial infarction, arrhythmias, valvular lesions with a thrombus and embolism, explaining the syncope or acute pericarditis or atrial cardiomyopathy as mentioned. Also on the list was aortic dissection and pneumonia. So what initial investigations would you do with this diagnosis in mind or with the differential in mind? I know we mentioned earlier on that we do a dipsticks. So maybe any other bedside investigations?
Bedside investigation, I would like to do during dipstick.
Yes.
Bedside. Blood gas as well. Yeah, and then forward to bloods, baseline bloods, ABC, menu, and first. Troponins.
So, and explain to us why you're doing each test.
Okay, ABC, really, I'm trying to exclude anogam function, presence to the kidney injury and presence to the defense of hemolysis. In regards to actually platelets and the function test, exclude CAP syndrome.
Any other blood investigation?
Popeye, Popeye and Bonky, it's Popeye and Popeye and Shocking. The time
Thyroid function possible.
Yeah.
Yeah. From the beginning, we can exclude electrolyte.
Any other bedside tests that you'd like to do in an emergency situation generally? Yeah.
So her blood glucose, as mentioned, was 5.2. Dipsticks was NAD, blood gas was done, noted to be normal. She had an ECG ordered and that list of blood tests done. Her white cell count was 12, HB was 11, platelets 373, normal UNEs. Her TROP-I was 1,340. Her ALT was 12, her BNP was 312. Also did an inflammatory marker CRP, which was 6, and TSH and T4 were normal at 0.82 and 10. And I've mentioned urine PCR there, but the result would have been received at a later stage. But those are the blood tests done. And this was the ECG. I don't know if I should ask the panel or the floor to interpret it, but it was a sinus rhythm, the rate of 66, and it was noted to have ST elevation in standard lead 1 and leads 4 to 6. No obvious chamber enlargement. So from this point, bearing in mind the findings, what is the most likely diagnosis and how would you manage the patient? Most likely diagnosis from the list.
An acute coronary syndrome.
Okay.
It's elevated myocardial infarction, so it's only the multidisciplinary approach of the cardiology. So first, typical therapy that we can give her is aspirin with the Pheochromocytoma. Those are agents and address the pain with morphine.
Maybe she's a pregnant patient, right? You are an obstetrician. What kind of management would you like to? So I agree with the aspirin, the multiplicity, 14% relative. What other things that you can, so for Pheochromocytoma, remember you've got a fetus, she's so pregnant. So what sort of things could you do now in the immediate for her besides anything else that? You might have on hand, but you can do. Only for the myocardial infarction. Remember, she's got blood pressure of
188/113.
don't forget the whole picture.
So for her, as Dr. Masondo rightly said, she was managed as acute coronary syndrome. So she was admitted to the critical care unit with involvement of the multidisciplinary teams, was put on continuous cardiac monitoring, and in addition to clopidogrel, aspirin, and therapeutic clexane and nitrates, BP control was also prioritized. As she was on methyl dopa, the dose was optimized. She was also put on hydralazine, and the cardiologist also suggested a beta blocker. This was not just overall after the one event, just on continuous evaluation of the patient with the raised blood pressures, and also supportive measures were instituted.
I think just from outside the institution, I want us to focus on some of the things that is available to us in our ward. So like nitrates, therapeutic clexane, aspirin, controlling the blood pressure, bringing the blood pressure down. Those are things that are in our control. Morphine for pain, all that can help as well in the immediate while we're waiting for cardiology.
Yeah. Any further investigations that while this treatment is instituted, any other investigations that you would consider doing for this patient? Bearing in mind her background history.
I think once she's stable, we have to better investigate for hypertension in young patients. She is 24 years old and she's came in with high BP, so we need to further evaluate for any secondary causes for the hypertension.
So what investigations would you suggest adding to what we've already done?
Okay, I think we can also book an echo for her. We can also send a urine for 24-hour, just to do catecholamines in
So
the.
you need to separate fund, you can't give it like that, right? You need to give us imaging, so further blood investigations that you'd like to do. Then further urine investigations that you'd like to do. Remember, she had a normal VTCR, and then obviously we going back to the imaging. And remember, we just had a CG that suggests coronary syndrome. So anything else that.
So from the blood, I think they did the thyroid,
Yeah.
they did thyroid function, because I think from the blood we did most of the
Right.
we have. And then for the urine, I would like to get the 24-hour urine.
For what? For protein?
For catecholamines
Okay.
and metanophins to also to exclude things such as Pheochromocytoma. And I will also the hypokalemia will also tell us maybe the taking of hyperembryo genetism on her, and an echo as well, and also just X-ray as well to see if there's any hypertensive changes on that X-ray, and what's other possible, or also a renal ultrasound so that we can exclude renal artery stenosis on her.
Okay. So the investigations done for her, in addition to what was already done, she had a renin and aldosterone levels done, which were normal. And we also did an autoimmune screen, which was also negative. They did a 24-hour urine protein quantification, came back as 0.15 grams per day. At this point, the metanephrines or 24-hour collection for urine catecholamines was not done. And then she was sent for further imaging. She had a chest X-ray and an echo. And the renal ultrasound, I think, was considered, but it was not done. And they did consult for coronary angiogram. But starting with the chest X-ray, not the best form, but it had clear lung fields. In this view, it might seem like she had cardiomegaly, but the echo was also done, so it doesn't reflect very well, but it reported left ventricular hypertrophy with a systolic function of 66%. The valves were normal and there was no pulmonary hypertension. So just to add on, so after these or during these investigations, the patient continued to have intermittent chest pains despite the management initiated, and the blood pressures were difficult to control. They were labile, oftentimes above 150/90 with headaches, and at certain times BPs were very low and the patient had pre-syncope. And she also had a labile heart rate ranging between 40 and 130. And so at this point, a CT angiogram was ordered to rule out another possibility. And at this point, an aortic dissection was entertained, seeing that the pains were still continuing and severe. So the CT angiogram was done, and it reported that the aorta was patent, normal in caliber, with no evidence of a dissection, aneurysm, or wall thickening. There was, however, a well-circumscribed lobulated retroperitoneal mass in the right paraortic region, measuring 5 by 4 by 7 centimeters, with significant compression of the right renal artery and a filling defect near its origin, raising concern of a thrombus. The adrenal glands, however, appeared normal. So the patient was suspected to have a neuroendocrine tumor. And after this finding, the endocrine and renal teams were also consulted. So the endocrine team advised collection of urine and plasma, for metanephrines and chromogranin A. They also advised the addition of doxazosin for BP control. And the results of the metanephrines, both in the plasma and urine, confirmed the suspicion of Pheochromocytoma. And as you can see, the predominant metanephrine was normetanephrine, above 14 times of the upper limit of normal. So the final assessment or diagnosis of the patient was 32-year-old young hypertensive with no prior workup for secondary causes. Now with the right-sided pheochromocytoma or paracanglioma, supported by the paroxysmal symptoms that she had and the hypertension, as well as raised catecholamines and retroperitoneal mass on CT angiogram. It was further complicated by right renal artery stenosis and thrombus from the compressive effects of the tumor, as well as acute coronary syndrome with transient ST elevation thought to be catecholamine induced. The patient's further progress while she was in the critical care unit, her symptoms improved after doxazosin was added and titrated up to effect. The other antihypertensives were discontinued except for methyl dopa. She was then transferred to the obstetric high care unit after spending 15 days in the ICU, and then later referred to Ialh High Risk Clinic at 28 weeks for assessment and further management. So when she arrived at Albert Lutuli, on arrival, she had another paroxysmal episode, severely high blood pressures and a syncopal attack on arrival. She was admitted to a high care unit and co-managed with an endocrinologist who further optimized the alpha blockade, and we continued the therapeutic lexane. and also consulted specialized surgeons for an opinion, and they planned a DMSA scan and surgery for post-delivery. However, she continued to have recurrent episodes of hypo and hypertension with syncopal attacks despite optimization of the medical management. And so the endocrine team advised preterm delivery on maternal interest because of the concern that the growing uterus was exerting pressure on the mass. And so an elective Caesar was done for her at 31 weeks. It was done under spinal anesthesia. It was a gentle delivery using forceps and without fundal pressure. The patient was then admitted to ICU for monitoring post-op, but later discharged after 1 day. She had no further episodes in the immediate postpartum period, and she is yet to be reviewed by the endocrine team for follow-up and by the specialized surgeons for further imaging and planning for tumor resection. Thank you.
Good morning, I'm Dr. Mmalo. I'll be presenting on pheochromocytoma in pregnancy. Pheochromocytoma, as well as paraganglioma, these are collectively known as PPGL. These are tumors that can secrete catecholamines. They are rare. In pregnancy, they occur in only about 0.07% of all pregnancies. Because of advances in obstetric care, as well as improved recognition, it has led to better outcomes for both the mother and the fetus. However, these pheochromocytoma, they can cause devastating consequences. Catecholamines, which are secreted by these rare neuroendocrine tumors, they can lead to debilitating strokes, life-threatening cardiomyopathy, and death. Women are particularly vulnerable at the time of delivery. This is because fetal movement, uterine contraction, and induction of anesthesia can precipitate acute release of catecholamines. And some of the cardiovascular complications that you can get with these tumors include your acute heart failure, cardiac arrest, and acute myocardial infarction, which can have permanent sequelae. However, when they are recognized and treated appropriately, they can be managed without serious complications for both the pregnant woman as well as the fetus. In terms of how they impact the baby, the fetus is susceptible to the surges in catecholamine as well. This is because they lead to this uncontrolled hypertension, which can disrupt placental circulation, leading to hypoxia and placental abruption or fetal demise. So the fetal loss is estimated to be about 9%. There is a role played by genetics. This is because nearly half of all patients with PPGL, they have associated germline pathogenic variants, which increases these women to be susceptible to these tumors. Some of the genes that have been cited includes your RET, your VHL, and as well as the rest of all of these other genes that have been listed there, including the neurofibromatosis type 1. What is important is that the PPGL associated with germline pathogenic variants, they generally will present at a younger age and often associated with multiple tumors, where you'll have a case where you'll have a bilateral pheochromocytoma, or you'll have a pheochromocytoma with a paraganglioma. This was, again, one of the studies really that was looking at the maternal and fetal outcomes of pheochromocytoma in pregnancy, and really was just to emphasize the role of the these pathogenic variants, that the role played by genes in these two tumors, and it consisted of 194 patients with PPGL in pregnancy, of which 66% had germline pathogenic variants, most commonly being the RET, followed by the SDHB, and a small percentage of about 5% with neurofibromatosis 1. And also, of these cohort of patients, a quarter of these patients had a family history of PPGL at the time of their pregnancy. In terms of how we diagnose these tumors, in terms of history, the diagnosis can be challenging. Yes, these patients will have symptoms of catecholamine excess, which are non-specific, and they can overlap with other medical conditions, including symptoms of pregnancy itself. However, the majority have symptoms of catecholamine excess, which will include palpitations, headaches, as well as a diaphoresis. And 77% of these women will have hypertension. Half of the women with PPGL in pregnancy, they are usually will be diagnosed at or after the start of the third trimester. Likely the reason being the result of difficulty identifying symptoms as those of PPGL earlier in pregnancy. However, the helpful clue to suggest PPGL, it can be the paroxysmal nature of the symptoms. So with hypertension being the hallmark of presentation that these patients will present with, it is important for us to be able to differentiate between gestational hypertension and PPGL, which can be difficult. However, we know with gestational hypertension that onset is after 20 weeks of gestation, and they can meet the criteria for preeclampsia if there is evidence of proteinuria, liver dysfunction, or platelets dysfunction. With PPGL, they are less likely to cause end organ damage, but it can still occur, which will further cloud the picture. In terms of what we test for to make the diagnosis, includes plasma fractionated metanephrines, as well as 24-hour urinary fractionated metanephrines and catecholamines. And they are strongly suggestive in terms of plasma urine metanephrines if they are greater than 3 times the upper limit of normal. And in terms of norepinephrine, if it's greater than 3 times again the upper limit of normal. However, it's important to note that urinary epinephrine and norepinephrine levels, they can be elevated during delivery and for a few days following delivery as part of normal physiology. In terms of the role played by imaging, it includes ultrasound in the first trimester, especially if it's a pheochromocytoma or a retroperitoneal paraganglioma is suspected. And there's also a role played by MRI without gadolinium, which can be used, especially later in pregnancy where visualization with ultrasound is limited. As for the computerized tomography, meta-iodopenzyl guanide scintigraphy, and PET scans, and they are not generally used because they can be harmful to the fetus and so on, should not be used. And I think it's because they emit ionizing radiation. In terms of how we manage, medical management is favored over surgical management for women with PPGL in pregnancy. And medical therapy is effective and it's well tolerated. And one of the studies to support this was that done by Bankus et al., who reported in 110 pregnancies where PPGL was diagnosed antepartum, with 57% of patients who were treated with alpha-adrenergic blockade. And the use of this medication prevented adverse maternal and fetal outcomes when used for at least 2 weeks. And your treatment goals, they recommend initiating the medical therapy when the diagnosis is made rather than waiting 10 to 14 days prior to delivery. And the advantage of that is that it will reduce the risk of hypertensive crisis and other complications associated with a larger relief of catecholamines such as cardiomyopathy or flash pulmonary edema. And when alpha and beta adrenergic blockade doses are titrated early in pregnancy, the patient can be medically optimized in case of an emergency cesarean section or a preterm delivery is required. We aim to achieve a low normal systolic blood pressure for a patient's age, which is between 90 and 100 millimeters of mercury, and the heart rate should average less than 90 beats per minute. In terms of your treatment options, I won't go through the whole table in the interest of time, but Basically what it shows the options you have in terms of the alpha adrenergic blockade as well as the beta adrenergic blockade, as well as the side effect and the special considerations that you have to be aware of. Just to take the drug that we use is the doxazosin. You can start it at 1 milligrams at bedtime. You can increase it by 1 milligrams daily based on the blood pressure measurements. And in cases of hypertensive crisis, you can actually increase it by 2 to 4 milligrams per day. In terms of the side effects, you'll make your patient aware that the first dose effect, they can have issues of osteostasis, peripheral edema, fatigue, as well as somnolence. And as well, in terms of the beta adrenergic blockade, you can use your drugs like your metoprolol. You can start it at 25 milligrams daily, and you increase it by 25 milligrams every 1 to 2 days, as to achieve a target average heart rate of 90 beats per minute. So if that's when, in these cases, perhaps when you want to get rate control. And the third line option will be your calcium channel blockers. One you can use, if you're familiar with nifedipine, you can start at 30 milligrams daily. You increase by 30 milligrams to target your systolic blood pressure up to a maximum of 120 milligrams daily, and those are the associated side effects with it. So just for emphasis, in terms of the medication of timing as well as treatment goals for pheochromocytoma as well as the paraganglioma in pregnancy. So we will start with the alpha adrenergic blocker. You recommend to start it at the time of diagnosis. You titrate it to a low normal blood pressure between 90 and 110, and you balance your dosing with side effects to find a maintenance dose, and you emphasize increasing fluid and sodium intake so as to minimize your side effect. You can intensify the therapy at 36 weeks to prepare for delivery if needed, and again, your goal systolic blood pressure is between 90 and 100 millimeters of mercury. As for the beta adrenergic blocker, you will be started at least 1 week alpha adrenergic blockade, and you must add only if you want to gain basically rate control, and you can titrate to a heart rate of 80 to 90 beats per minute. And your calcium channel blocker will be the third line, which is will be started about after titration of the alpha adrenergic blockade for 2 to 3 weeks, and add only if patient had persistent hypertension despite adequate alpha and beta adrenergic blockade. There are other medications that you can use, such as metyrosine. It inhibits the rate limiting step in catecholamine synthesis. However, it is a category C drug in pregnancy, so it's generally not recommended. As for methyl dopa, it inhibits the decarboxylation of levodopa, which intuitively could reduce norepinephrine and epinephrine levels. However, the study that that showed that there was not much benefit in terms of reduction in urine catecholamines or improvement in PPGL-related symptoms. And in fact, some case reports suggest hypertension may worsen with its addition in pregnant patients. As for the magnesium sulfate, we know we use it a lot to treat preeclampsia, and has a good safety profile in pregnancy. It causes direct vasodilation, but also blocks peripheral catecholamine receptors. It reduces the release of catecholamines from PPGL tumors, and it is proposed as an adjunct to medication used intraoperatively during PPGL resection or in management of PPGL crisis. However, there was one study that showed that magnesium sulfate controls systolic blood pressure well until the tumor is manipulated. So you will need additional medication if you're using magnesium sulfate. I won't go that much on these ones, but in terms of emergency medications, you can use intravenous medications. It should be reserved for use only in emergency situations such as hypertensive crisis. Hypotension should be avoided. And in terms of fetal monitoring, it should be in place prior to giving any rescue medication. And one drug is your phentolamine. It is an alpha adrenergic blocker, which is available as an IV lyophilized formulation in vials containing 5 milligrams. You can initiate at a dose of 1 milligram and followed by a repeat 5 milligram boluses or a continuous infusion. And you expect a response to be maximum in 2 to 3 minutes after the bolus, and it will last for at least 10 to 15 minutes. And you can then mix it up where you take 100 milligrams of phenytolamine, 500 mils of 5% dextrose, and water, and it can be infused at a rate titrated for a blood pressure control. It has been, however, associated with severe maternal hypotension and maternal and fetal death. So it should be reserved for use in emergencies such as hypertensive crisis. Another drug is intravenous nicardipine, which can be added if hypertension control is not achieved with phenytolamine, and you can start at an infusion of 5 milligrams per hour and can be titrated to the target goal blood pressure. As for esmolol, it is an intravenous beta-adrenergic blocker. It should only be administered in conjunction with alpha-adrenergic blockage to help with rate control. And a bolus of 0.5 milligrams per kg can be given over the first minute, followed by continuous infusion of 0.05 milligrams per kg per minute for the next 4 minutes. So the onset of action is almost immediate with the peak effect in 5 minutes. However, there are no human studies that have been performed to determine the safety of esmolol in pregnancy. It should only be used when maternal benefit outweighs the risk to the fetus. As for the IV hydralazine, it can be used for acute hypertension in pregnancy. However, it can precipitate acute coronary syndrome in patients with PPGL, so it's generally not recommended for use in pregnancy. And as for sodium nitroside, it has been associated with stillbirths and fetal cyanide toxicity and should not be used. In terms of how we monitor and counsel these patients, so the patient should be taught to monitor BP and heart rate at home and to obtain blood pressure and heart rate in the supine, sitting, and standing position every morning and evening. We encourage frequent daily dosing adjustment, which may be required during initiation of therapy, as well as intensification of the treatment prior to delivery. The monitoring will help to minimize the negative effect of hypertension on the fetus, and also to minimize the side effects. The patient must be counseled to increase fluid and sodium intake, and also this will help help to minimize the severe orthostasis as the alpha-adrenergic blockers take effect. In terms of the surgical consideration, it is typically not required as medical management is generally well tolerated and effective. There was a study to support this, a study which included 230 pregnancies that showed that antepartum surgery was not associated with better maternal or fetal outcome. It should be considered on patients who remain hypertensive despite maximally tolerated alpha-adrenergic blockade, or patients who are unable to adhere to medical therapy. It should ideally be performed second trimester after alpha and beta adrenergic blockade is titrated as tolerated, and should not be performed in third trimester as the fetus is larger, which will limit visibility in the abdomen and pelvis. Extensive surgery should be avoided, such as open surgery for a large abdominal paraganglioma or a stenotomy for a removal of a cardiac paraganglioma. As for the delivery consideration, cesarean section is traditionally been preferred for patients with PPGL in pregnancy. It is generally recommended due to concerns that physiologic changes during vaginal delivery increase the risk of catecholamine release, and vaginal delivery with uterine contraction and fetal descent could increase the pressure on the PPGL tumor in the abdomen and pelvis, which will lead to this massive release of catecholamines. However, there are studies that have suggested that a subset of women with PPGL may have a safe vaginal delivery, such as those with a small tumor, low catecholamine burden, or tumor outside of the abdomen or pelvis. And also in cases of multiparous women, as they deliver quickly, and so vaginal delivery could be considered. And as for the elective termination of pregnancy, so majority of PPGL in pregnancy can be managed safely with medical or surgical therapy. So it should, termination should be considered when the life of a pregnant woman is at risk. Also in cases of pelvic or urinary bladder PPGL, as they are located in precarious positions. especially as the fetus is growing. So you can, in those cases, consider elective termination. Also, in cases where there is persistent hypertension despite alpha and beta adrenergic blockage, and where the location or size of the tumor makes surgery high risk. In all these instances, you will have to involve the multidisciplinary team, which is needed to assess the risk of the woman as well as the fetus, but also to provide support to the patients as they are making these decisions. As for the post-delivery recommendations, PPGL should be surgically removed after delivery. We should allow time for the woman to recover from the delivery itself and for the uterus to involute. And the importance of contraception should be emphasized. And those not known to have predisposing germline pathogenic variants for PPGL, they should be offered genetic testing. Plasma fractionated metanephrines and imaging should be repeated prior to subsequent pregnancies to identify new tumors, recurrence, or metastatic disease. So to conclude, the PPGL, they can be dangerous, especially when the diagnosis is made after delivery, and early recognition of these tumors is associated with better fetal and maternal outcomes. Medical therapy is effective and well tolerated, and surgical therapy can be reserved for more complex cases. And these women with PPGL and pregnancy should be offered germline genetic testing.
Thank you, Dr. Nwala, for that presentation. So I think just a few points. I think so as in terms of take-home messages. So chronic hypertension in pregnancy, we know we diagnosed either the patient under 20 weeks or they have a history. I think for the patients who come in with a history of chronic hypertension, the young hypertensive, we should be looking at doing things that to exclude or do a chronic hypertension workup in these patients. I think that's one take-home message. The patients who we diagnose early in pregnancy, we have to obviously individualize care and how much of imaging, how much of testing. I mean, this doesn't mean, remember we always say, Dr. Ramran, we always say common things occur commonly. So in a patient like this who presents after 20 weeks, our first diagnosis is going to be, okay, besides the acute coronary syndrome, would have been chronic hypertension with superimposed preeclampsia, right? And it's difficult to make that diagnosis sometimes. Not every patient is going to have a pheochromocytoma. But yes, it is important also for us to keep an open mind and also individualize care. I think that's the take-home message. Look at your patient, look at the history of the patient. How long has she been hypertensive? Is she on treatment? And what have we done in terms of offering a full chronic hypertension workup? A sort of base lab, sort of minimal should be at least offering them an echo and some form of ultrasound, abdominal imaging, sort of like an ultrasound. So these are sort of some of the basics that we can take home, but also remember at the same time, common things do occur commonly, but always keep an open mind when you see these chronic hypertension after 20 weeks. It can be challenging, not only for our neuroendocrine problems or endocrine issues like Graves or pheochromocytoma, but also other conditions like chronic kidney disease. A lot of the times you have patients with underlying chronic kidney disease, chronic hypertension presenting after 20 weeks with high blood pressures. It can also be, and then you've got an abnormal U&E and you have to decide, is this acute kidney injury from the preeclampsia, or is this chronic kidney disease and this chronic hypertension? So these are all can be challenging in medicine, as it doesn't occur often, but always try and keep that open mind. Try and take a good history from your patient, examine your patient properly. These are the only things that I can tell you that can actually help us in trying to differentiate between the various chronic diseases versus our obstetric adverse events like preeclampsia, HELLP syndrome, and so forth. Anyway, thank you very much, guys, and have a good rest morning. Thanks.